Welcome to the Healthy Living Series, a series of talks brought to you by the University of Alaska's Summer Sessions and Lifelong Learning in partnership with Foundation Health Partners. My name is Joan Braddock, and I will be your host for this summer series. The Healthy Living Series, in its 8th season, has been a lecture series held in person in past summers. The COVID-19 pandemic and social distancing guidelines required that we rethink the format for the series this summer. We are delighted that KUAC has agreed to support the new format for the series as a weekly TV broadcast. We are also grateful to our speakers who were willing to be incredibly flexible in adjusting to this new format and appreciate the time they are donating to help us all live a healthier life. Before I introduce tonight's speaker, I want to let you know that you will be able to view the talks online after they have aired by going to the UAF Summer Sessions' website at uaf.edu/summer/events. And now I'm delighted to introduce our speaker for this evening, Dr. Laura Brunner. Dr. Brunner specializes in pediatrics and considers it a privilege to participate in children's health care. In addition to seeing patients at Tanana Valley Clinic, Dr. Brunner is the medical director for the Fairbanks Memeorial Hospital Pediatrics and Neonatal Intensive Care Units. She attained a medical degree from the University of Minnesota Medical School and an undergraduate degree from the University of Minnesota College of Biological Sciences. On a personal note, Dr. Brunner enjoys cooking, the outdoors, and spending time with family. Tonight, Dr. Brunner will be sharing her expertise on the hidden ways childhood experiences impact adult health.
Hi, I'm Dr. Laura Brunner, and I'm a pediatrician here at the Tanana Valley Clinic and at Fairbanks Memeorial Hospital, and I am super excited to be able to talk about a topic that is near and dear to my heart and that I really enjoy talking about. We're excited to be able to do this UAF Summer Lecture Series in a little bit of a different format and still be able to do it. So I am here sitting in a room by myself, and so I'm going to take this mask off so you can see my whole face while I'm talking today, but just excited to be able to do this in this different format. So the topic that I'm going to talk about today is the hidden ways that childhood experiences can impact adult health. And what we're going to be talking about is something called adverse childhood experiences, or ACEs. And we start with this slide when I talk about this topic because it is a really impactful slide and one that I think sticks in people's heads. So this is a CT scan or a CAT scan, and it is of a child's brain. So on the one side, you can see a typically developing brain, or a child that has had sort of typical exposures through life, and you can see the size of the brain, you can see how the brain is growing. And then you can see the brain next to it, and that is a child who experienced extreme neglect for the first 3 years of life. So we know that the first couple of years of life, there's a whole lot of development and physiologic changes that happen, and this just shows what effect extreme neglect can have in terms of brain growth and development. So as we talk here for the next little while, just keep this in the back of your mind on a big scale of what can happen when kids have different experiences in the first couple of years of life. And then I want to talk about a little bit of science for a few minutes, and that is the why. So why does that happen? Why is that growth different? Why do we think that we see things that happen in childhood impact the adult that you become, or the health of the adult that develops? And the reason for that is sort of that fight or flight response. So everybody's had kind of that moment where somebody jumps out of a closet and scares you, or something happens and you get that warm flush, you get your heart beating fast, you get that kind of can't breathe kind of feeling. And that's a hormone response. So that is that fight or flight response where you have a big empty of hormones that cause that those physiologic changes, or those things that happen in your body. And that's a stress response. And so what happens with a stress response is you have hormone secretion and hormone secretion and hormone secretion if you have stress after stress after stress. You also have that hormone secretion in your brain. So if you are a child who is experiencing stress after stress after stress, you're having different chemicals in your brain than a kid who's not having that. What we also know is that there's ways to buffer that relationship, or ways to sort of moderate the amount of stress hormones that happen, or how those stress hormones are interpreted. And the way to do that with kids is really a relationship with a strong adult, or a strong adult relationship. in the short term, stress can be really beneficial. So if something scary is happening, if there's a bear jumping out of the woods at you, you want that stress response to happen. In the long run, that sort of chronic stress response without buffering or without the relationship of a strong adult can have a really significant impact. And that impact can cause what we saw in the first slide, or can change the way the brain grows and develops. It's kind of a phenomenon of constant wear and tear. So if you're constantly having that stress hormone response, it's a wear and tear response on your brain. The other interesting thing is that it can actually change what genes are expressed or what genes get turned on in your brain. So we're all born with a set of genes. Some of them are turned on and making proteins, and some of them aren't. Some of them get turned on at various time points during life. So when you have that constant hormone exposure or that constant wear and tear, it can actually change which genes get turned on in a child's brain through the course of development. I'm going to shift gears for a minute and talk about something called ACEs. And many of you have heard of ACEs, some of you may have not. It's an acronym that stands for Adverse Childhood Experiences. That I'm going to walk through a little bit of the history of the ACEs work and where that study initially came from and how it was initially done. And I will add the caveat that there are a number of physicians when it first came out who just didn't believe it, who didn't think that it could actually be a thing. And so it's been really interesting to kind of talk with different groups of people about this topic over the last 10 years or so. The initial study was done as a collaborative between the CDC, or the Centers for Disease Control, and Kaiser Permanente. So Kaiser Permanente is a large healthcare management organization. So they have groups of members or people who are part of their organization. And then they also have all of the claims data, so all of the billing data related to that, and they have the clinics. So they have information about people, about what diseases that they have, and they have sort of a closed system or a group of people that's one group of system. And what they did is they interviewed 17,000 adults. So a lot of people participated in this initial study. The people who participated, the average age of participants was 57 years old. And because it was a closed system, they had medical histories for all these people. So they could call and ask questions, and then they could look at their medical records and see what health problems that they had. I'm just going to spend a couple minutes describing this study because of the importance of this initial study. What they did is they called those 17,000 people and they asked them questions about their childhood. So they asked them questions about, did this happen in your childhood before age 18? They asked them about these 10 things. So they asked about physical abuse, sexual abuse, emotional neglect, and physical neglect. So those were the 5 abuse and neglect questions that they asked. And then they asked 5 other questions about home environment or household environment as a child. They asked if you had witnessed domestic violence, had mental illness in the home, had a family member who was incarcerated, if there were alcohol or drug problems in the home, and then parental separation or divorce. And then what they did is take that data, so all of the people who answered that questions, and sort of look at it, and then look at how that was associated with health outcomes. So these were the 10 ACEs that they asked everybody about. And that determines your ACE score. So you'll hear us talk about ACE score a little bit here through the rest of this conversation. What the ACE score is the total number of ACEs experienced. So it's a fairly crude measure. The way that it works is if you experienced physical abuse 1 time or 400 times in childhood, that's an ACE score of 1. So if you answered yes to one of those questions, that's 1 ACE score. It's also additive. So if you were exposed just to domestic violence, then that's an ACE score of 1. If in your home there was parental alcoholism and physical abuse, that's an ACE score of 2. A history of physical neglect, sexual abuse, and parental divorce, that would be an ACE score of 3, and so on. And in this study, it was up to a maximum score of 10. The key finding in this study which was a little bit surprising to a lot of the people who worked on it, and subsequently surprising to the people who read the study, was that the higher your ACE score, so the more questions that you answered yes to, the greater risk for adult health problems later in life. So we're going to show this in just a second here. This is a little bit of prevalence data. So prevalence is when we asked these questions, how many people in the community answered yes to these questions. So these are the 10 ACEs that we just talked about, so sexual abuse, domestic violence, and on down the list, and the percentage of people who said yes, they had experienced that ACE before age 18. So 21% of people answered yes, they had experienced sexual abuse. Domestic violence in the home was 13%. Substance abuse in the home was 28%. You can read through the slide, but a number of these numbers were pretty surprising. And remember, in this study, this group was a sort of middle to upper class group. So 40% of the people in this study had a college degree, and over 70% had some college. Only 7% did not have a high school degree. So as you can see here, adverse childhood experiences were remarkably common in this group. And so back to that key finding of the higher your ACE score, the higher likelihood to have health problems as an adult. The key finding really is that 2/3 of the people in this study reported at least one ACE, and only 1/3 reported no ACEs. In that 1/3 that had no ACEs, they were consistently healthier across many, many, many measures, and we'll talk about that in a minute. But it really looked at the concept of what happens in childhood, and what happens in that first 18 years has a huge impact not only on the adult that you become, but also the health of the adult that you become. This is a big long list. It's not meant for you to be able to read the list. It's just meant to show a big long list. And what it shows is this is a list of all the different things that have been linked to adverse childhood experiences scores now. So when we talk about the health as an adult, we're looking at all different kinds of markers. So people who have a higher ACE score have a higher risk for things like heart disease, asthma, diabetes, cancer, COPD, smoking, alcohol abuse, clinical depression, suicide, teen paternity, employment problems, on and on. This list goes for a whole slide and even longer than that. But the big picture is that all of these different things have each individually been linked with a higher ACE score. Makes you higher risk to have these health problems as an adult. And I think that's been a really interesting thing to talk with healthcare providers about and talk with kids and families about, because it's not always intuitive that if you're exposed to physical abuse as a child, that you have a higher risk for heart disease as an adult. But clearly the study and the subsequent one afterwards have shown that over and over again. The other thing is just to look at what's called a dose response. And so what this slide is talking about is the higher number of ACEs that you have, the higher risk of health problems you have. So 1 ACE is not the same as 5 ACEs. So if you have 1 ACE, you're less likely to have health problems than someone who has 3 ACEs or 5 ACEs. So there's an additive effect. For each ACE that you increase your risk of health problems. This is what's called a dose response relationship. It's kind of like the concept of the more gas you put in the car, the more miles you can drive. The more ACEs you have, the higher risk of health problems that you have over time. So that's sort of the history of ACEs and the initial study and the initial work that was done looking at that in the past. And I'm going to shift gears for a minute and talk about Alaska specifically. So that was a fairly narrow population. It's been replicated in a number of populations across the United States and had sort of a more broad look at different populations over the last 15 years. But I'm going to talk about Alaska for a little bit, because every once in a while, as Alaskans, we see data from the lower 48 and we say, yeah, but that can't possibly apply to us. We're special. And so I'm going to talk about the work that's been done in Alaska to look at that. And we're looking at what's called the Alaska Behavioral Risk Factor Surveillance System. And that is a program here in Alaska. And every single month since 2013, 200 Alaska residents or more, age 18 and older, are randomly selected and interviewed over the telephone regarding their health practices, day-to-day living habits, to reach an annual sample size of 2,500 people. People are surveyed also about ACEs that occurred before they turned age 18. So you get a phone call and they ask you they say, are you willing to participate in the survey? And then you get asked a whole bunch of questions, and you get asked about ACEs before age 18, and you get asked about your current daily habits and about your health. So this is different than Kaiser because the state doesn't have access to people's health data. You get asked about your health data, so it's a self-reported tool. These are the different areas in Alaska that are surveyed. So there's an equal number of interviews that are conducted across all of these regions in Alaska. These are the 7 state-defined public health areas. You can see that Fairbanks is in green right in the middle there. And so there's a purposeful oversampling of non-urban areas in Alaska. So the goal is to make sure we don't just ask the questions in places like Anchorage or Fairbanks, that we reach smaller communities throughout the state. And I'm going to show you a little bit of the data that's come out of that from the state of Alaska. So there's a bunch of graphs here coming up next. I'll walk you through them. Then on the x-axis, or the bottom axis here, is the ACE. And I'm going to pause for a second and talk about what ACEs were asked. So remember, a few minutes ago I showed you a list of 10 different ACEs, and it had 5 abuse and neglect questions and 5 home questions. Some of the studies ask all 10 of those questions, and some of the studies ask 8 questions. And there's some different reasons why, and not saying one way is right or wrong, but just know that there's 2 different ways to look at this out here, and you just want to know what your maximum score is. When they changed from 10 to 8 on some studies, the 2 questions that they stop asking are the neglect questions. So the emotional neglect and physical neglect questions. And the thought process behind that is that those might be slightly more subjective or less discrete than the answers to some of the other questions. I think that we can all appreciate the concept that neglect as a child is incredibly important and has an incredibly important potential impact down the road. So it's just important to know, when you look at a study, what is your maximum score? Is it 8 or is it 10? So in these slides that we're going to look at next, the maximum ACE score is 8. So it's those 5 home questions and then the abuse questions, but not the neglect questions. So here on the bottom of this graph across the x-axis, you'll see each of the 8 ACEs that's asked in the state of Alaska questionnaire. So emotional abuse, physical abuse, sexual abuse, intimate partner violence or domestic violence, household substance use, household mental illness, parental separation or divorce, and incarcerated family member. And then on the y-axis, or the one that goes up, that's the percentage. So the percentage of people who answered yes to that question. In blue is a 10-state comparative sample. So the CDC has sample sets from other states of people who've answered these questions. And so this is a data set or a group of information that's 10 different states and Washington, D.C., and that's the blue area. And then green is Alaska. So green is how Alaskans answered these questions compared to the 10 states. And what you can see on this graph is that across the board on all 8 of those ACEs, in Alaska, Alaskans answered yes, they had experienced these things in childhood at a higher rate than the 10-state comparative data set. So to say it another way, we have more ACEs in Alaska than in other areas of the lower 48. There's a couple that I want to call out specifically. One is incarcerated household members, so that's on the very end of the graph all the way on the end down here. And that is in the 10-state area, 5.7% of people said as a child they had an incarcerated household member. And in Alaska, we're answering yes to that question 11.3% of the time. So almost 2 times as many children have an incarcerated family member in Alaska than in other parts of the United States. To look at this one other way, so this is again taking Alaska's data or Alaska's yes answers to those questions and comparing it to a different group. So maybe it's we didn't like the 10 states we compared it to before, so now we're going to compare it to 5 different ones. So this is just a different comparison and a different way to look at it. And what it shows is the same thing. So consistently across all 8 of those ACEs, Alaska kids are seeing exposure to those ACEs or experiencing those ACEs at a higher rate than other parts of the United States. So in Alaska, we have really high rates of kids witnessing domestic violence. We have high rates of incarcerated parents, high rates of substance use in the home, and high rates of physical abuse. So we just compared Alaska to the rest of the United States, and then I think sometimes in Fairbanks or the Fairbanks North Star Borough, we have the potential to say, yeah, but that's Alaska. Fairbanks is special. We're different in Fairbanks, or we're unique in Fairbanks. So I'm going to take a second and show you Fairbanks data. So this is the same idea as the graph we looked at before. So on the bottom axis is the ACEs listed on the bottom, and then the percentage of people who answered yes to that question on the y-axis or the upright axis. And now what we're comparing in green is Alaska, and in blue is the Fairbanks North Star Borough. So what this shows is that Fairbanks is the same as the rest of Alaska. So we said that Alaska is worse than the rest of the United States in terms of number of people reporting that they have an ACE, and Fairbanks is the same as Alaska. So we can kind of extrapolate Fairbanks is also worse than the rest of the United States in terms of number of people reporting ACEs. So the goal of showing all this data and all these graphs is to just try to put the information out there that kids in our borough, in our town, in our community are experiencing these things in childhood. One question that comes up a lot when we talk about this is sort of what is the cost or what happens, because we're talking about health outcomes as an adult. And so this is a slide to look at insurance payer. Who is the insurer, the person who's paying for the insurance for Alaskan adults? So this is a little bit of a complicated graph, so I'm going to take a minute to walk through it. So on the bottom axis is the type of insurance. So the first tall bar is Medicaid as a type of insurance. The middle bar is employer provided. So I work at UAF and I have healthcare as a part of my job there. And then the third bar is self-purchased. So the person who has insurance is paying money to have that insurance coverage. And then on the y-axis or the tall axis is the percentage of people who have an ACE in that category. So if we focus on the first bar, that's Medicaid. So the number of people who have Medicaid, and that 20.9% of patients or people who have Medicaid have 0 ACEs. The 20.7, the orange bar, is number of people who have Medicaid who have 1 ACE. The yellow is 31.7%. That group of people has 2 to 3 ACEs. And then the number of people who have 4+ ACEs, so either 4 or all the way up through 8, is 26.7 ACEs. Employer provided, you can see the 0 ACEs is a larger portion compared to Medicaid, and the 4 ACEs is a smaller portion. And then self-purchased, the 0 ACEs is an even higher portion, and the 4+ is a smaller portion. So looking at this information, the higher number of ACEs you have, the more likely you are to be on Medicaid or to have a government paid insurance from that standpoint. And the first couple of times I look at this data, I have to actually put it into a way that it makes sense to me or a way that it makes it real to me. So we can look at pie charts and graphs and all of those sorts of things, and we can extrapolate all kinds of numbers. But another way to look at this is through actual kids. So if we think about Alaska kids in the and how their distribution of ACEs, one thing that I like to think about is this slide here. So this is 100 kids. So if I went to a random sample of schools across the Fairbanks North Star Borough, so I went and took a class from Salcha Elementary and a class from North Pole Elementary and Pearl Creek and Hunter and Joy, and I got 100 kids and sampled them from all across and put them into a school gym. Don't do that during COVID times, but put those 100 kids in the school gym. Statistically, how many ACEs would each of those kids have? So now I have these 100 kids in the gym here, and the dark green is how many kids in that population have 0 ACEs. The light green is how many kids have 1 ACE. The orange is how many have 2 to 3 ACEs, and the dark maroon on the bottom is how many kids have 4+ ACEs. So a random sampling across the Fairbanks North Star Borough, this is what I would find of 100 kids, how many fell into each of those 4 categories. Now if I shift the data a little bit, and I take 100 kids who are experiencing low income. So now I have 100 kids who qualify for the free and reduced school lunch program. in our schools, and I take those 100 kids and I put them in a gym. Look at what that does to shifting the number of ACEs that those children have. So remember, experiencing low income is not an ACE in and of itself, but when I took 100 kids who are experiencing low income, I have no children who have 0 ACEs at this point. We've completely eliminated that category. I have a number of kids who have 1 ACE that are the light green color, a whole lot more kids who have 2 to 3 ACEs. And look now, the 4+ category is across the whole bottom row and into the second row there. So if I take a population that's experiencing low income, all of a sudden I have kids who have a much higher ACE score on average. And then we shift and we move to the domestic violence team that works with kids and families here in Fairbanks. And I take 100 kids who are working in the domestic violence center. And so by definition, they have 1 ACE. So remember, exposure to domestic violence is an ACE. So by definition, all of these kids have 1 ACE. But if I take those 100 kids who've experienced domestic violence and look at what other ACEs do they have, or what other exposures do they have, out of that 100 kids, there's only 1 child who that is their only ACE. All the rest have multiple other ACEs. So this really illustrates the concept that ACEs travel in packs, that they're not necessarily isolated events, and domestic violence is the strongest predictor for that. So if we look at this graph and kids who've witnessed domestic violence, over half of them have 4+ ACEs. So it's not a single ACE of domestic violence, it's multiple other things that are happening in the home. And remember back to the health outcomes that are tied to 4+ ACEs, the insurance piece that's tied to 4+ ACEs, and so just trying to connect those dots or put those pieces together. But it's really important to remember, if we're seeing a kid who has 1 ACE, there's a decent chance that there are other ACEs with it, especially if that ACE is domestic violence. And a little bit ago, I said that ACEs are kind of a crude measure. So they're, if you have 1 exposure to physical abuse or 400 exposures, that still counts as 1 ACE. It also counts if it happens at any time point before age 18. So there's not a different ACE score for if it happens when you're 6 months old or 5 years old or 17 years old. So what this graph is trying to do is look a little bit at the concept of when in childhood do you accumulate your ACEs. So I think we can all appreciate the idea that a 6-month-old brain is different than a 4-year-old brain, is different than a 15-year-old brain. And what this graph is looking at is by what age have kids accumulated half of all the ACEs they were going to get in their life. And so on the bottom axis is how old a child is, and on the side axis is the percent of kids who've reached half of their ACEs by that time point. So what this graph shows is by age 3, half of kids have received half of their ACEs. And so in that first 3 years of life, that really critical brain development time period, over half of kids are getting half of their ACEs before they're even old enough to go to preschool. And I want to touch for a second on addiction and substance use. And if you haven't watched Dr. Pete Dillon's conversation about substance use and addiction, I would encourage you to do that. I'm going to touch briefly on a couple concepts, but he obviously covers that topic in much more detail. And I'll be talking the next few minutes just about the interrelationship and the sort of chicken and the egg link between that. This is just to say that a person who has 4 or more ACEs in childhood, so again, things that happen in childhood, is 12.2 times more likely to attempt suicide, 10.3 times more likely to use injection drugs, and 7.4 times as likely to become an alcoholic. So again, illustrating that fact of things that happen as a child can have an impact on the health choices and life that you have as an adult. To talk about addiction just for a second, and just state sort of the ritualized and compulsive comfort-seeking behaviors, and there can be addiction to a whole number of different things, but really it's that idea that constantly need a comfort-seeking tool. Tying that to ACEs, so individuals who have 5+ ACEs are 3 times more likely to misuse prescription pain medications, 5 times more likely to engage in injection drug use. And those who have a significant ACE score, and again, sometimes we've talked about 4+ or 5+, but a significant ACE score, however it's defined, are more likely to report chronic pain and to take chronic prescription pain medications. And 80% of patients who are seeking treatment for opioid addiction have at least one ACE. And I want to talk for a second and acknowledge again the fact that I'm in a room here by myself recording this with no audience because of the coronavirus or because of COVID. And just think about all of the different things that we've talked about and what do we think is happening during this time period of quarantine and isolation and no schools from an ACE standpoint. So all of the data that I told you about before is under normal circumstances, not during coronavirus times. And these are just some snapshots from the ADN and the Fairbanks Daily News Miner over the last couple of months about topics related to ACEs. So domestic violence hotline calls increasing, increasing concern about isolation and fear. And remember, tie that back to the concept of that kid who's experiencing domestic violence, that's not the only ACE likely happening in their home. So if it increases significantly during this time, what is this going to mean not only for our children in this time period, but adult health outcomes in the next 20 years? And I'm going to shift gears for a second and talk about the economics of ACEs. So I really hope that none of my Lathrop High School economics teachers are watching this right now. And if they are, that they'll cut me a little bit of slack because I am not an economist. But I'm going to attempt to tie some of these ACEs concepts to actual dollars in our state. So Alaskan adults who have 4 or more ACEs compared to a group that have 0 ACEs. So we're taking a group of Alaskans who have 4+ ACEs and a group of Alaskans who have 0 ACEs. So 2 different groups of people. The group with 4+ ACEs is 49% more likely to be unemployed, 274% more likely to be unable to work, and 92% more likely to earn less than $20,000 a year. These are what's called Heckman curves. These are economic curves, and it's the concept, if I have $1 and I want to invest it in something and make a difference, what is my return on my investment? So where do I put the dollar to have the biggest bang for my buck in terms of investing that dollar? And so the top curve here shows if I invest that dollar in preschoolers, I get a higher return on my investment. So on the bottom x-axis is age, so preschool and then post-school age. And then on the y-axis is how much return on your investment do you get, or how much impact did your $1 make. So if I invest $1 in preschool or that early time period, I get a bigger return on my investment than school time period, than post-school time period. The bottom graph extrapolates that further. So essentially, if you want to get the biggest bang for your buck, you invest back here in pregnancy. So those first 3 lines there are first trimester, second trimester, and third trimester. So your biggest return on your investment is actually investing before the kid's even born, investing in the pregnant mom. And then where do we actually spend money? So on the bottom axis is age 0 to 20, and on the y-axis is the brain's capacity to change. So think about all the changes that happen in normal childhood development. So a 4-month-old is probably rolling, but probably not sitting up on their own, is making some noises, is smiling and laughing, but is not talking, is not walking, does not having a meaningful way of mobility, is not crawling, is not getting themselves around on their own. A 2-year-old is walking, won't stop talking, is following directions when they feel like it, is feeding themselves, has an opinion and a communication pattern. And that's just in a 1.5-year time period, how much the brain had to change to make all of those developmental changes in that time period. And so the biggest time period when the brain is capable of change or has the easiest ability to change is that young age. And we know that from a language experience. It's a whole lot easier to learn a foreign language as a young child than it is by the time you're old like me. It's not to say that we can't change brains later on, it's just to say it's harder. And so right now our spending, or the money that we are spending on programs to, quote, change the brain, increases as you get older, but the brain's capacity to change goes down. This is one more look at some of the ACEs data. So this is a hypothetical experiment of what if we took our ACE rate in Alaska and we decreased it just to the rate of 2 other states. So the 2 states that we chose to compare it to are Arkansas and Vermont. And we chose those 2 states because they're obviously in very different parts of the country. They have very different political spectrums. And in both of these states, they have a higher ACE rate than Alaska. So we did the experiment of what if we could just reduce Alaska's, if we had a magic wand and we could just reduce Alaska's rate down to the same as Vermont and Arkansas. So that's essentially reducing our ACE score by a half. So we're not going to be able to eliminate all ACEs, but if we could just decrease it by a half, and we looked at just the cost savings that we would have associated with these 6 things. So obesity, adult Medicaid recipients, smoking, binge drinking, diabetes, and arthritis. If we just reduced our ACE score by a half and just looked at the cost savings associated with these 6 things, we would save $90 million a year in the state of Alaska. So $90 million is a number that doesn't really resonate with me. I don't know how much money that is. I don't know what I could do with that. And so attempted to just sort of put that in terms that I understand. So we could hire 915 kindergarten teachers and pay their salary and benefits with that and still have $97,938 left. We could buy 18 million boxes of Girl Scout cookies at the current price of $5 a box in Fairbanks. We could buy 22,500,000 N95 masks if they were $4 a mask. And we could do 450,000 coronavirus tests at $200 a test. We could buy a Boeing 737 and still have $17 million left for fuel and crew. So pick any one of these things where you want to spend your $90 million, but that's what $90 million would get you in the state of Alaska. Another way to look at this, again, if we reduce that ACE score by a half and just brought it down to a similar rate of Arkansas and Vermont, these are the changes that we would see in some of these other measures. So we would have 3,546 less people who don't own a home. We would have 5,565 less people who didn't graduate from college, and on and on and on. If we look at our behavioral health measures, so if we, again, just reduced our ACE by a half, we would have 9,375 less depressed people in Alaska. If we look at our food insecurity rates, so again, that half reduction there, we would have 4,176 less people who had to cut the size of or skip a meal because they couldn't get food, 2,464 less people who used the community food bank. And again, all of these are prior to coronavirus. So we know what's happening in our community in terms of increased demand at our food bank and the work being done to help support our local Fairbanks community food bank during this time. All of these numbers and changes are prior to coronavirus happening. I'm going to shift gears again for a second and focus on kids in Alaska. So I've put the website on the bottom of this slide, but this is a new report about the state of Alaska's kids that just came out this last week. It's 146 pages, so you can feel free to log on and read it in your spare time, but it is a very lengthy report. What it's looking at is the concept of what tools and systems do we have that exist in Alaska to support early childhood. So we've talked about all the different ways that early childhood is a period of incredible growth and development. We've talked about it's the time period when kids accumulate at least half of their ACEs that they're going to have in their life. And we know that those early childhood experiences can have a significant impact on cognitive growth, on emotional and social development, on physical development, and ultimately adult life. ACEs have the opposite effect. So negative things that happen in childhood can result in deficit in skills and abilities, can increase health risks into adulthood, driving down productivity, quality of life, and increasing social costs. And then we talked about already, but we'll say it again, that COVID-19 adds more questions. So the two graphs up on the top show what a young population we have in Alaska. So 13% of our population here in Alaska is under the age of 8. That's really high compared to some other states. So we have a lot of young kids here in Alaska. And then we've talked about the rates of physical abuse of children in Alaska and how high they are. This is just one more way to look at it. And this is the substantiated maltreatment reports are higher in Alaska. So this is from the Office of Children's Services. This is not self-reporting of physical abuse. This is a substantiated maltreatment report through the Office of Children's Services. And so in the United States, the rate is 12.8 per 1,000 children. In Alaska, that's 19.2 per 1,000 children. So again, take two big elementary schools here in the Fairbanks North Star Borough. So take Pearl Creek and Joy Elementary School, that's got you close to 1,000 kids. 19.2 of those children, on average, have had a substantiated maltreatment report. And as we continue to recover from COVID-19 and what happens during this pandemic, it's going to be even more important to understand how the services that serve families that depend on how are they being affected? How will they affect families' health? How will they affect mental health or behavioral health? How will they impact economic well-being? And lots of these questions about what happens when early childhood facilities close, so childcare or other child development centers close or have to restrict back, but parents remain essential workers. What happens to those kids? Where are those kids, and who's taking care of those kids? And what about communities that depend on itinerant providers for either healthcare, for early intervention services? How will the change in delivery and the change in availability impact what kids and families have available to them? This report is also split apart by region. So there's a Fairbanks report. This is the first page of it. Again, the website is on here. Essentially, to what it shows for Fairbanks, it goes through a number of markers of socially available services, some health markers, some population data. And essentially what it shows for Fairbanks is there's a few markers that were a little bit better in Fairbanks. There's a few that were a little bit worse, and some were right on average with the rest of Alaska. So I've just spent 45 minutes talking about a whole number of depressing things, about bad things that happens to children, what an impact that has on your adult life. And I think it's really important to take a minute and just acknowledge the fact that what happens as a kid is not your destiny, is not you are doomed to have this life or doomed to have poor health outcomes. And go back to what we talked about initially, which is that buffering or that relationship with a strong adult and what an impact that can have in terms of the ability to develop community and compassion and kindness. And that is the concept of resiliency. So resiliency is really the most important resource to help a child cope with violence or cope with what's happening. And that's a strong relationship with a competent, caring, positive adult. Most of the time that's a parent, but it doesn't have to be. It can be a grandparent, it can be an aunt, it can be an uncle, it can be a teacher, it can be a mentor, but it's that strong relationship with an adult to help buffer the exposure to violence or buffer the negative things that are happening in a child's life. I couldn't miss an opportunity to talk about what resiliency resources exist in our state and talk about how you can access them. So there are a whole number of materials that are available on the Resiliency Coalition website. And there are some different curriculums and different tools that are available as well. The History and Hope resources are listed up here. They're really excellent resources looking at how to build resiliency programs and how to build resiliency in individuals. So feel free to check these out. I want to touch on Fairbanks and what's happening in Fairbanks for a minute. So I have been incredibly privileged and humbled to be able to meet a number of our community members here in Fairbanks who each in their individual circles and their individual work are working hard on resiliency work and building families and using what's called strength-based curriculum. So it's how do we help families identify kids' strengths or identify the positive things that happen both in their family and in their home and build community around those and build compassion around those. And I would just put forward the concept that we are incredibly lucky in Fairbanks to have such talented and caring individuals. There are people who are very smart, who are wanting to do this work and help kids and families in our community, and they care a lot. That an example of one of the projects that is happening, and again, this is just in the work that I do at Foundation Health Partners, is an education curriculum looking at trauma and addiction for our inpatient labor and delivery and pediatric staff and nurses to help them think about these concepts and learn about these concepts so they're able to meet families where they're at. And to talk about the concept of trauma-informed care. So trauma-informed care is really the idea of meeting people where they're at. And so it's shifting that mindset of not using judgment and not starting from a place of, oh my gosh, what are you doing? And instead going to a place of, oh my gosh, what has happened to you to get you to this point in your life? And how can I be of help or have a positive impact on your life? And really the idea that shame is not a tool to drive social change. So saying to somebody what you are doing is bad is going to have less long-term potential than saying, how can I help you? What can I do to help you make a change? Are you interested in making a change? And again, I would echo what I said before, which is if you haven't seen the addiction conversations from Dr. Pete Dillon, they're a good tie into this information. And then to talk about resiliency a little bit. So my favorite description of resiliency is the concept of ordinary magic. So it's nothing that you have to go to school for 20 years to learn how to do. It's nothing that is not inherent in many people. It's the idea of supporting kids, supporting families, and helping them have a better future to build that buffering capacity when negative things happen in their life. And so it's the idea of that supporting with good parenting or another significant adult in a child's life, we have the opportunity to help a child's cognitive and social development and can proceed positively even with a lot of adversity, even with violence. So yes, our first choice is always to prevent ACEs, but even if ACEs occur, and ACEs are gonna occur, even if they do occur, how can we help children and families build resiliency to be the best adults that they can be down the road? And the last thing that I would sort of touch on is this concept that we've talked about economics, we've talked about science, we've talked about data, we've talked about studies, all of those different pieces, and we put it in dollars and cents, and we put it in kids in a school gym. But really the idea that families with young children are the infrastructure of Alaska. There's nothing more important to Alaska's future than building on that infrastructure and supporting that infrastructure. Maximizing the potential of kids is much easier and cheaper if we start them out the first time. That there are a whole number of people across the state of Alaska who are working on this topic, and I have blatantly stolen their ideas and slides and concepts, and so I just want to say thank you to this group of people who's dedicated to this work across the state. And just close with a moment of saying thank you for spending an hour listening to this topic. Thank you for caring about the children of Alaska and the families of Alaska and learning about this concept. And reminding that each of you already has power. So you have power because you've already given an hour to paying attention to this. You've already donated your time to learning about it and asking questions about it. And you have the power to impact the future adults of Alaska. And that's just by intervening in the life of a child or providing support to a family with young children. That doesn't have to be complicated. That doesn't have to be hard. That can be in the moments when you ask from a place of true, genuine wonder, how are you doing and what can I do to help? Thank you so much for your time and attention to this concept and for tuning in to watch this lovely Zoom conversation that we got to have together.